Thanks so much. Good morning, good afternoon, good evening, wherever you might be. And thanks to Ben and John for organizing this conference. It's always great to have a chance to compare notes with other countries and what other countries are up to, and also have a chance to talk about the German health system with people who are actually interested in hearing about it. So I'll be talking about managed competition in Germany, which I'm sure you all know. The basic idea is Alan Einthoven's sort of idea of a purchasing strategy, where there's a sponsor that basically sets the rules and ensures that competition happens on good things like price and quality rather than on bad things. And so this is the idea that Germany has sort of implemented and follows since the mid-1990s. And so we have about 25 years worth of experience from the German incarnation of managed competition. And so what I'll start off with just giving a high-level overview of this sort of basic setup of the social health insurance in Germany, sort of the origins of it a little bit as well. And I'll sort of stay away from many of the interesting little tidbits and also only focus on the insurance side of things. Johannes will speak about sort of the consumer side, and many of the things that I think he'll flag will also apply to the German context. So I'll focus on the insurance market in Germany. And then I'll give you sort of a little bit of overview of the recent trends in the insurance market, more descriptive, sort of what happened to the number of plans, the premiums, and so forth in the German market. And I'll try to sort of throw in a couple of comparisons with the US, and especially Medicare Advantage, and a little bit the exchanges, in case that's sort of helpful for getting the conversation going. Now, you might think that social health insurance sounds pretty boring. I think the name is a little bit lame, especially when you compare this to Medicare Advantage or Biden Care or something a bit more fancy. But what I really want to leave you with today is that the German insurance market is really not a sleepy backwater anymore, and it's really quite an interesting market. There are lots of sort of oddities to it and lots of interesting bits. There's some overlap with the US system and other country systems. And I think maybe the fact that there's overlap actually makes it possible to learn a bit from the German market, for example, the German system, and apply this to the US. It's not super fundamentally different in some ways. And so maybe that actually makes it feasible to, rather than revolutionize the American system, to sort of have incremental change in some of those margins anyway. And I'll try to flag those as I go along. But first, the obligatory map of Germany, of course. I think you all know where it is. This little thing up here, Kiel, is my hometown, where I'm from, on the Baltic Sea, close to Denmark, far away from the Netherlands, I guess, and Belgium, I guess, is closer than my hometown, at least from the Netherlands. The German system is sort of not a cheap health system. It's the third most expensive in the world by percent of GDP, and the fourth by sort of spending per capita. It's still, of course, a good bunch away from the American levels of spending. And for what it's worth, our life expectancy is slightly better than the American system. We have about 81 years, the US about 79 or so, although I would not attribute that just to the healthcare system, of course. Let me start off with sort of a brief note on the historical origins of the social health insurance, which I think is sort of important to understand the baseline, sort of where the system is coming from, and sort of where it sort of was in the mid-90s when competition started in the system. And in some ways, I think John Gruber's talk just now, I think just brings home that the German social health insurance is really very successful in many ways politically. It's now about 130 years old and sort of has survived 2 world wars, a bunch of upheaval, reunification, and other kinds of stuff, and sort of is very much ingrained in the sort of in German society, I guess, and sort of what it means to be in Germany and what it means to be German. So you could say that maybe it had sort of an early birth and has a long life expectancy compared to some of the other policy initiatives that we're now talking about. So in 1881, Otto von Bismarck, who was the chancellor back then, announced a package of social insurance programs, including health insurance. And on the left here, you have the sort of declaration by Us Wilhelm, which is the emperor of Germany at the time, who sort of clarifies there's going to be health insurance mandate for blue-collar workers mostly, sort of people working in high-risk professions like mining and so forth. They would be sort of obligated to have insurance. And I think this is sort of very clearly less motivated by sort of the welfare effects of health insurance as we think now, and much more by political factors. At that time in Germany, there was a lot of pressure from the left, from trade unions and the workers' movement. And in a sense, this law sort of preempts the rising pressure on the government from that side of politics. It's also not entirely new and innovative, so they sort of piggybacked on existing so-called sickness funds, which existed for various guilds and firms and industries, and which basically served the purpose of providing sick pay. If somebody gets sick, these sickness funds would provide income replacement, basically. And healthcare, paying for healthcare expenses was a much smaller part when this all started. So overall, I think, it's a very politically sort of savvy move, sort of preempted the pressure from the left and just built on existing institutions, and this delay that John Gruber was talking about, and sort of getting an initiative off the ground. Actually, they already had something to work with, and it was pretty easy to sort of get going on that. As you can see on the right, there's sort of a initially very large number of health plans, because these are organized basically small self-help groups, if you wish, with relatively small enrollment. And then by the mid 70s or so, we reached 90% of coverage of the social health insurance, which is sort of where it's been at since. So in more recent days, and this is what I'll focus on, of course, is sort of the system has sort of settled a little bit in some respects. And I think you'll sort of recognize a few of these sort of basic features of the insurance system setup, partly what Sung Mei talked about yesterday with Taiwan, but also sort of overlap with some of the Chilean systems features. The social health insurance covers 90% of the population, which maybe is a little bit surprising on the first glance. The rest of the population is insured in private health insurance. And we can talk about that a bit more. This is sort of separate system with, by now, limited interaction with the social health insurance. But it's not actually, social health insurance is not universal in Germany. That's sort of important to note, I guess. We have these three principles: solidarity, corporate structure, and subsidiarity principle, which I think, is sort of determines a lot of what the actual design of the system looks like. So the solidarity principle basically says from each according to her means to each according to her needs. And so what this means in practice is we have standardized benefits. We have a contribution rate that's not a fixed premium, but varies, is attached to wage earnings. So higher earners would pay more, lower earners pay less, and sort of puts this solidarity principle in practice, basically. The corporate structure, I think that's really a very interesting feature of the German system, and one reason maybe why it's politically so successful. The decisions in Germany are made sort of jointly by the main actors in the health system, and the government really does provides the framework for it. So the benefit package, for example, is not set by the government and sort of is set by a federal joint committee that consists of the associations of the dentists, the outpatient providers, hospital, and health plans. So the government only sets the basic framework, and the negotiations of what goes into the benefit package actually is mostly done by these actual actors in the health system, and sort of keeps the government one step removed and maybe somewhat insulated from political pressure to sort of meddle with the benefit package as well, which I think is a sort of politically very savvy move to do that. The corporate structure also, I think, leads to this common approach to payment systems and price setting and sort of the rest of it. Basically, everybody always has to get together to make decisions together about what happens. If there's a disagreement, there's a mediation process, but in principle, these sort of actors in the health system have to come to agreement on all these different things, and sort of that seems to work quite well overall. We also have the subsidiary principle, which is basically to say that there should be minimal administrative hassle and political influence. And so the social health insurance actually is largely self-managed. As I said, there's these sort of stakeholders getting together. The government mostly stays out of it. This also means that the social health insurance is mostly self-financed. There's some sort of infusion of tax funds into it, but in general, the social health insurance and each individual health plan has to balance their budget. And so they use the contribution rate as a sort of main lever to sort of adjust, to sort of link up the spending and the revenues that they get. But in principle, the social health insurance's mandate is to sort of be independent financially as well. Now, the German health insurance system, I think, is very interesting. These health plans are sort of very odd entities. They're not for profit. They can't vertically integrate. They must contract with all providers in the regions that they operate in. It's a multi-payer system, so you can actually choose between different kinds of plans. The benefits are standardized, the networks are standardized. The plan has to accept you, guaranteed issue, community rating, all that stuff. And sort of nonetheless, we have multiple of these health plans sort of floating around. And I'll come to the idea of why we have them floating around in just a moment. But it's sort of very interesting economic institutions. They can't really act on many of these margins that we think about in the US market, like negotiation with providers or sort of restrictive networks and sort of contracting in that sense. The one interesting thing about the German system is that we have this sort of weird premium. As I said, it's a contribution rate on wage earnings up to a sort of maximum. It comes in two parts now. There's a uniform contribution rate, which is 14.6% on wage earnings. That is the same for all plans. And then depending on whether you're enrolled in a plan that is an expensive plan in the sense that it has a bad risk pool or operates in high-cost regions, your plan might charge a supplemental fee on top of it. So that fee is shown separately and certainly increases the salience of premium differences. And that's something we can come back to a little bit later. I think one thing that's interesting about the German system, and it's sort of maybe for many German health economists a puzzle about the American system, is that in our case, or in the Germans' case, I should say, insurance is portable, so it's not tied to the employer. Your employer will pay part of your premium, actually half of it. Both the uniform rate and the supplemental fee is split 50-50 between the employee and the employer. But of course, you could just switch employers and go somewhere else, and your insurance would just stay the same in most cases. So insurance is fully portable, and I think that is something that my view sort of has fallen a bit off the discussion in the US context, where I think this idea of job lock doesn't get as much attention as it used to maybe back in the day. Let me briefly talk a little bit about the payment system before I sort of come to the dynamics in the market itself. I think you realize by just staring at it, there's certain elements of Medicare and sort of Medicare Advantage floating around. And in fact, you could argue that the Germans maybe have learned from the US system already and adapted a bunch of stuff, bunch of innovations that came from over here into the health system. So on the sort of payment side of things, you have the members and the employers paying this uniform contribution rate into a central fund that basically pools all the revenues and then sends a risk-adjusted payment to the health plans. And in case you're wondering, yes, we have our own word for this. It's called mobilitätsorientierter Risikostrukturausgleich. And no, that's not one word, it's two words actually, but you can try to say it 5 times fast and see how you're doing on that. In any case, in addition to this uniform rate, there's a supplemental fee that goes to the health plans, as I said, that varies by health plan depending on sort of their financial needs and what they need to balance their budgets. On the sort of payment side of things, I think one thing that's quite interesting, we have a DRG system on the hospital side, and we have this really interesting payment system on the outpatient side, where the plans pay capitation to the regional physician associations, who then have this basically a relative value scale in how they pay office-based physicians. And these physicians themselves are often sort of single physician practices. They're not larger practices in most cases. And sort of these are, owner-operated firms, if you wish. They all are subject to the same basic structure of the payment system. There's some small variation in sort of regional base values that they use to apply these payment scales. But I think the thing that's really interesting is these regional physician associations, which are now risk-bearing entities. So they get the capitation from the health plan and then have to pay their local physicians that each themselves have practice budgets. So there's sort of a limit on how much money they can get, but they're risk-bearing and they actually do a lot of the administration, right? They process all the claims that come from the office-based physicians and sort of take care of that. And the health plans do actually not do that as opposed to the US system. Whether or not that's more efficient than the US system, not quite sure. The German system overall sort of suggests that it has a low administrative cost of about 5 or 6% or so, which is much higher, of course, in the US. But I think these calculations do not include the sort of costs that the regional physician associations actually generate. So the administrative cost, I think, of these associations is not counted in that overall administrative cost figure. What's missing in this graph is sort of the pharmaceutical side of things, and maybe that's the one element where plans nowadays have a bit more leverage and kind of can behave a bit more like economic institutions. They can do selective contracting via competitive tender for generics, and then sort of get the insured and the members to use those generics. So that's where a little bit more of the leverage of the plan comes along with kind of how they can use their market size to sort of extract better prices. But otherwise, they have to all contract with all hospitals and all physician-based association, all office-based physicians in the regions that they operate in. And so that's sort of, there's no way around that. You can't do networks around this. And likewise for the hospitals, they have to contract with all the insurance plans. So there's no way around that. Now, so coming to the competition piece of the managed competition, so I think historically plan choice was just limited. There's basically no way you can get out and can choose a different plan. You have to choose whatever your occupation group sort of has on offer. And if you're in the coal miners sickness fund, then eventually the kind of risk pool becomes pretty bad and your premium goes up by quite a bit. And so in the mid 1990s, there was this perception that there's sort of unfair premium rates across different demographic groups and different industry groups. They all get the same benefits. Why should the coal miners pay more in terms of premium just because they have a worse risk pool? And the sort of political solution to that was to offer competition. So everybody can now choose what health plan they want to be in general. And sort of the idea was that, this would sort of force the premiums to converge and would sort of leverage competition for all sorts of good things that these plans would then come up with, where again, they're sort of pretty heavily constrained compared to US plans anyway, and what they can actually do. But that was sort of the basic idea. So that raises this question of what would these plans actually compete on? The most obvious one, of course, is the supplemental fee and sort of the price that they have to deal with. And that actually does turn out empirically to be the largest feature of people making choices across plans. They can offer some additional benefits and additional features like these exotic vaccinations. If you go traveling or something, need a yellow fever vaccination, you can have special benefits in some plans for that. And these bonus programs and sort of slightly different deductible choices, although that's not really very common. These sort of contractual features are not very common. And then if you look at the what sort of review sites recommend, they say, look at the customer service quality and whether they have a phone hotline or something, which I think it seems all very tame and timid compared to the US context, what plans are competing on over here. And so I think it's sort of interesting question of what actually drives competition in the German system. But let me come to sort of a little bit the sort of market dynamics over the last 2 decades or so since choice started. And as I said, sort of it's important to recognize where the German system comes from. It comes from a setting of having loads and loads of plans. And certainly, as you can see on the left here, there's like a very large consolidation over time, and very rapid one, especially as the competition starts in '96. The number of plans, especially small plans, shrinks very quickly, and has sort of been stabilizing around 100 now in the last couple of years. Now, I should say that not all of these health plans that are sort of listed on the left here as in existence in the social health insurance are actually available to everybody. Companies can still choose to have closed health plans. So Daimler or BMW have their own sort of firm-linked health plans that only their own employees can enroll in. They could choose to open themselves, and the fact that many haven't done that, is about 25 or 30 or so that have remained closed. Mostly suggests that they have a pretty good risk pool and that they would probably pay more if they went outside of their own sort of local risk pool.
2 minutes, Sebastian.
Thank you. Great. So there's some regional sort of variation plans can offer in different regions. I think one thing that's interesting is we have loads of plans. There's more than 40 plans in every single region. And if you compare this to Medicare Advantage, which is, these numbers are from a recent overview by Richard Frank and Tom McGuire, you actually see that the American Medicare Advantage program has a lot fewer plans and certainly a lot fewer insurance across the counties in the US. This is just looking at the contribution rate. As I said, one of the objectives of this reform in '96 was to force the reduced contribution rate to converge. There's sort of interesting bits and pieces to this. They changed this the contribution rate to this uniform rate plus the plan-specific fee. They did various changes to that. That changes the salience of these plan differences. That's sort of interesting, but I guess we won't have time to talk about that. You can look at this sort of across the regions. They all have similar median fees, similar spread. Some of the regions are cheaper, and you see some plans here. There's one plan in this region over here that has a 0% supplemental fee, which of course is sort of very salient and very appealing to many consumers. This mostly reflects regional differences in costs rather than anything else. In terms of market shares, sort of another way of looking at this, we have a couple of large national players. The top plan in Germany by enrollment takes about 15% of the market. The top 5 get about 50%. It's still a lot less than what would show up in the US Medicare Advantage program, where the top 2 insurers have about 90% of the market. In fact, if you were to look at some measures of market concentration, like the Herfindahl Index, Germany sort of is still pretty concentrated, but a lot less so than the American Medicare Advantage market, which I think is really quite interesting. So the German market is more competitive, at least on these measures, than Medicare Advantage, which is interesting. And hopefully we emphasize the point, as I said, that the German insurance market is not such a sleepy backwater anymore. So let me just close maybe by just noting a couple of challenges maybe that are continuing in the health insurance market in Germany. One is this sort of process of consolidation is still ongoing. So I think we haven't reached the steady state with regards to the number of plans and the premiums. There is some issues with sort of differences in premiums across regions, as I just showed you, that's mostly driven by cost differences and therefore differences in sort of the expenditure that different kinds of plans have depending what region they operate in. The choice sets are pretty large, and consumers often do not seem to switch, despite the fact that the differences in these premiums is now very salient with a supplemental fee on top of the overall uniform fee. The health plans in Germany, as I said, they're sort of slightly strange institutions, but they're sort of smartening up. And if anything, they're probably learning from their American counterparts in terms of sort of how to go about extracting money from the system. This is sort of just to maybe highlight their similarities with the US in terms of how plans behave. This thing on the bottom here is from a German newspaper, and basically it's the boss of the largest German health insurance plan saying something like, "We, the health plans, continuously cheat." Of course, it caused a big uproar in Germany. Maybe in the US was not quite that surprising, but in Germany that was sort of a big deal and a big finding. So let me maybe stop there. I think in terms of what are the lessons for the US, I think there's probably lots to be learned. And I think some of the most obvious ones are the portability of insurance. It seems sort of perplexing that this wouldn't exist in the US. Of course, there are reasons for that too. And I think the idea of having this corporatist setup where the different stakeholders of the health market sort of come together and have to reach agreement is an interesting feature of the German system, and one would wish this could exist in the US, but I'm not entirely confident that that is even feasible. And I haven't talked very much about pharmaceutical purchasing, including John Gruber's comments, but that's actually an area in Germany that's really quite interesting. It's not so much related to the managed competition piece, but just to flag there's sort of other elements of the German insurance system that are outside the sort of insurance competition that are really quite interesting. So let me stop there and see if you guys have questions.
Thanks very much, Sebastian. That was fantastic. So we'll consolidate questions and I'll do some questions for both of you at the end, in the next, after Johannes's session. So with that, let me turn it over to Johannes, and another thank you for spending your Friday night with all of us, though I guess maybe you're locked down, so the opportunity cost is not too high. But thank you anyway, regardless. You're muted, Johannes.
Yeah, I know. I was trying to get unmuted, but somehow it wasn't responding. So that's why I stopped sharing my screen. So let me try again. Let me try again.
Got it.
Okay. Okay, good. So you hear me clearly and you see my slides? Yes.
Yes.
Okay. So yeah, thanks a lot, John. Thanks for involving me. Thanks for this very exciting conference. I've learned a lot already in this past day, and I've also learned quite a lot preparing for this, because I'm not Dutch, as John mentioned, and I'm not really an expert in managed competition. But that said, I'll try to give you a brief background about what's happening in the Netherlands. And as Sebastian mentioned, we coordinated a little bit, and I'll focus most on the consumer side. In particular, I want to show you an application of my own research together with John and Ben, in fact, showing that choice frictions are very important also in the Dutch context. And we want to highlight the unequal consequences that can bring about. And then I want to add with the conceptual question of how should we think about the value of offering choice in health insurance and other social insurance programs. And I'll tell you a little bit more about work I've done in that context as well. Okay, so first a brief background on the Dutch context. So there has been a big health insurance reform in 2006 when a new system came in place. So the old system before that was a combination of a mandatory social health insurance in the lines of what Sebastian has been explaining in Germany as well, which was mostly which was mandatory for people with lower income, but it covered 2/3 of the population up to the reform. It's health insurance that is provided by the sickness funds, and individuals pay, and the payments they make are a mix of a uniform premium. So there is it's again not allowed to differentiate prices. There is no it's guaranteed issue, no pre-existing conditions, and it's combined with an income tax as well. And then already before the reform, there has been a gradual introduction of risk-adjusted transfers to insurers, depending on the individuals that took up the insurance plans with them. And so then people had the option to take private health insurance as well, and quite a few people were uncovered as well. Okay, so then they introduced this new system in 2006, and that included a mandate for all. So everyone was mandated to get basic health insurance. But within the mandate, there is still some dimensions of choice that people have. And the first dimension of choice that people have is a deductible choice, which is a very simple choice. So everyone is obligated to have a deductible of at least 375 euros in annual expenditures, but they can voluntarily increase that deductible up to 875 euros. So I'll talk a little bit more about that later, because that's exactly the dimension that we've studied. Another dimension of choice that people have is to get supplemental coverage, which includes dental and physio, but it's only about 5% of the expenses. So in contrast with the German system, another dimension of choice is that plan providers can limit the network that insurees have access to. But in practice, that hasn't worked fantastically so far, because it's only used by, or it's only chosen by less than 10% of the Dutch households. And so what we're having is sickness funds and private insurers that are competing on price, and then there is a system of risk adjustment transfers that, like in Germany, is also very similar as what we see in Medicare Advantage and the exchanges in the US. So if you set up a managed competition system, then you need a regulator, and the Dutch set up a new Dutch healthcare authority that oversaw like the different pieces of the healthcare market here. So there is a healthcare insurance side, there's a healthcare purchasing side, and there's a healthcare provision side. So what I want to focus on mostly is this relation between the insurers and the insurees. And in terms of financing, I mentioned it already a little bit. So this is something that was already there in the old system and that was taken over by the new system as well. Every individual pays an income-linked premium that goes to the government, but they also pay a flat rate premium. So it's the same for everyone that goes to the health insurer. And then the government pays a risk adjustment transfer to the health insurer as well. So on this risk adjustment transfers, there has been quite some research, and it's heavily evaluated, and there have been many revisions of the algorithm to determine how the risk adjustment transfers should be set. So in fact, there have been 7 reforms. So this has started in 1993, and so over the course of 27 years, there have been 7 reforms where they include more and more variables to determine the risk adjustment transfers. Okay. And so there are various papers by Richard van Cleve and his co-authors. And this table that I'm showing you here comes out of one of these papers. And what they're doing here is they're comparing the health expenditures, or the expenditures a given individual makes, and then they subtract the risk adjustment transfer that the insurer is getting. Okay, and so what we're showing is here how much you're undercompensated for individuals with different conditions as being specified here. And this is information that is coming out of a big health survey that is done by hundreds of thousands people in the Netherlands. It's information that is not included in the algorithm to determine the risk adjustment transfer. And so we can see for people that we expect to be still undercompensated, how well the algorithm is performing. Okay, and so they're showing this for the various improvements of the algorithm, how much the undercompensation is decreasing as we're improving the algorithm. And it's quite interesting to see how it has evolved over time. So first, the conditioning was only on age and gender. Then they included region. Then they included source of income. Then they included pharmacy cost groups. Then they included diagnosis cost groups. And then they included socioeconomic status as well, and whether people had multiple years of health conditions as well. And so you see that the algorithm is doing better and better over time. And there's also a different type of information that is used in the Netherlands, for instance, compared to the US, which is, for instance, socioeconomic background of what your main employment is. I think is information that is generally not used in the risk adjustment transfer algorithms that are being used in the US. So let me turn to the provision of planned choice, which is really a key part of a managed competition system. And the idea is that by having choice, we're introducing competition. And in doing so, we're lowering prices and/or we're improving quality. And I've put a quote of Enthoven that Sebastian referred to before as well. So the idea is that we structure the market for competing health plans to establish equitable rules, to create price elastic demand and avoid uncompensated risk selection. Another dimension of choice is that it allows consumers to match their heterogeneous preferences. And here the idea is that by introducing this kind of choice, this is compatible with Americans' preferences for pluralism. So this is a piece that Enthoven wrote to thinking about introducing evaluating managed competition in the US as well. So it's compatible with Americans' preferences for pluralism, individual choice and responsibility, and also having universal coverage. Okay, so one issue with introducing planned choice and having consumers being able to match their heterogeneous preferences is that it very much presumes consumers' ability to make choices that reflect their preferences. Okay, and so we're, I think, co-responsible of thinking that consumers always are doing so, because in most of the models that we're still writing today, it's very much a standard assumption that people are optimizing or making choices that are maximizing their utility, and through their choices, they're revealing what their preferences are. And that very much contrasts with the growing literature on the limitations that people face in trying to make effective choices. And in that context, it's quite surprising that the regulation, also in terms of providing choice, is so strongly focused on supply side inefficiencies. So we're very worried about particular insurers trying to attract particular individuals depending on the risk adjustment transfers in place. And so also in the Netherlands, there has been lots of work on that and trying to improve that as much as possible. But there, at the same time, there is very, very little work trying to think about demand side inefficiency and what the potential equity implications are of the demand side inefficiencies. And I think one major reason for that is that it's just very hard to measure choice quality. It's very hard to know what the best choice is for a given individual and how far his chosen option deviates from their best choices. And if we want to think about equity implications in particular, then we need a lot of information on other observables that we often don't have in different contexts, and we definitely tend not to have them for a representative sample. So here comes in the Dutch context and the Netherlands again. And so we've seen Swedish examples and Norwegian examples yesterday, but also in the Netherlands, we have really a fantastic data environment with population-wide data, individually linked administrative registers with information on wide ranges wide ranges of data with various sources of information. So that includes lots of socioeconomic variables. The economic outcomes often go beyond income. It includes information on the liquidity that people have, how indebted they are, the types of assets that they have. Also a lot of information on their education, the field of studies, and so on. So very rich information there, but also a lot of information on health. So we know there are health expenditures in this data. We know the hospital diagnosis for different individuals. And then on top of that, there are various surveys that are organized. Some of these surveys are really, really big efforts, like this health survey that has been organized twice in the past 10 years. And they're again linkable to all these administrative data. And then there's some insurance choices as well. And we have data on that as well. So we know what insurance individuals are insured by and what some of the choices are that they make. Okay, so that brings me to the application that I wanted to talk about. And this is a paper that I've done joint with Ben and John and Thomas Minton, who is a PhD student at the LSE, where we try to leverage this rich data to analyze the social determinants of the quality of deductible choice. Okay, so let me briefly set up the context of the paper here. So we're focusing on this deductible choice that I mentioned before, which is relatively simple, and it's also independent of all these other choice dimensions. So each individual has to make this regardless of what plan or what providers they end up with. And so everyone is forced to take a minimum deductible of 375 euros. So this is compulsory, but then they can add a voluntary deductible of at most 500 euros in 100 euro increments. And if they go for the extra 500 euro deductible, they get a premium reduction of, on average, 250 euros. So what we've done in our work is estimate a risk model where we use individuals' past health expenditures and their demographics. And based on that, we predict the expected expenses that they're going to make. And using this prediction, we're going to say what the optimal choice would be for each individual if they were in a frictionless world. Okay. So what I'm showing you here is the distribution of healthcare costs in the Netherlands. So this is ex post. And from an ex post perspective, we see that a lot of individuals could have gained by taking the highest deductible and taking this big reduction in the premium. While from an ex post perspective, a lot of people are better off with the lowest deductible and the higher premium. The question, of course, is from an ex ante perspective, to what extent can people anticipate that they will end up making very low expenses, or whether they can anticipate making very high expenses. So we do this prediction model that I've mentioned, and we see that the extent to which people make high or low expenses, high health expenses or low health expenses, is very predictable from an ex ante perspective. Okay, so what I'm showing you here on the horizontal axis is a probability of making low expenditures that fall below this compulsory deductible of 375 euros. Okay, so if this probability is very high, then you're predictably healthy and you're best off taking this extra 500 deductible. But if this probability is low, meaning that you're going to be predictably sick, you're being best off with this 0 deductible and paying the higher premium. Okay, given that it's about a deductible difference of 500 euros and you're getting a compensation or a premium reduction of on average 250 euros, if you're risk neutral, the threshold should be exactly at 50%. But given that the financial stakes are relatively small here, even if we introduce very risk-averse preferences, that only moves the threshold by a little bit. Okay, for CARA preferences that are quite risk-averse, the threshold is moving to 56%. Okay, so from an ex ante perspective, we know that there are a lot of we know the 2 minutes only. That's not. You
can take a little bit more. We can eat a bit up.
That's not good. Okay, but I'll go quicker. But a lot of people know that they're not going to make any expenditures at all, and not going to make any expenditures at all, and a lot of people know that they are going to make high expenditures. So let's see how they do. Let me show you that in this graph. So here I'm showing again people's probability of making low costs, and then I'm comparing, or then I'm showing for people, depending on the probability of making low costs, what's the take-up rate of this 500 euro deductible. So for people that are predictably sick, indeed, almost no one is taking the deductible, as they should be. And if they become more and more predictably healthy, more and more people are taking up this extra deductible. So they're going in the right direction, but even the people that are predictably healthy, that have a 90% probability of making expenses that fall below this compulsory deductible, only 20% of people are taking up this deductible. So take up here is way, way, way too low. Okay. So what we do in this paper is to show how these take up rates now differ by different socioeconomic variables. Okay. And one of the main takeaways is that things like education, but not just years of education, but also the type of education, especially people with quantitative backgrounds, are going to make the better decisions. Okay, so we see, for instance, that people with the highest education here are much more likely to take up this deductible than, for instance, the high school dropouts. Okay, and one thing we can do is rank people based on the quality of the choices they make. and then show what the average characteristics are of these people depending on how good they are in making these choices. And if we compare the top 5% decision makers with the bottom 5% decision makers, then we see that they're quite different in their demographics. The top 5% different decision makers are, for instance, younger. Also, environmental factors play an important role, but it's really the socioeconomic status that is really different for people making the high quality choices versus people making the low quality quality choices. So looking at the income dimension, for instance, we see that top 5% decision makers have on average a gross income of 100,000 euros a year. For the bottom 5%, it's only 40,000 a year. And the discrepancy is even bigger if we look at net worth. Okay, so one takeaway on the value of insurance choice from the Dutch experience is that providing this option to take a larger deductible in the Netherlands is providing very limited value because people are bad at making this relatively simple choice. And this on top ignores government's implementation costs of allowing for these choices and also the decision costs that individuals bear individually by having to go through this exercise. But on top of that, the gains from choice are very unequally distributed. So it's the high income people that on average are healthier and that gain the most from being able to take a higher deductible, but they're also better in making these decisions. Okay, so in the light of this, we can wonder whether we should reconsidering offering choice. Here, the choice is not horizontally across different plans, but it's really a vertical choice of getting more coverage or not. And if we think that we shouldn't be providing choice, then we have to think about how much coverage we should provide. So if I can take one more minute, John, then I just refer you to this review paper that I've been doing with Nathan Hendren and Camille Landem, where we think about whether we should allow for choice or not in social insurance. And the first thing we do is look at the different social insurance programs that we have, and we compare the extent to which we allow for choice, for instance, in the US versus the comparison country that we have here is Sweden. Okay, and we've seen in different countries already that there is no plan choice whatsoever in different countries, but also in the US, in some insurance domains, we accept that there is no choice of how much coverage we want. For instance, in unemployment insurance in the US, you don't have any choice. For workers' compensation, you don't have any choice on how much coverage you want. On the social insurance programs where we do have choice in the US, like disability insurance and long-term care, also in other countries, we often see that there is no choice provided there on how much coverage we want there. If we want to evaluate the dimensions along which we should evaluate whether allowing for choice is a good thing to have or not, then am I still good on time, or you tell me, because I'm looking at the.
You're way over, but finish the thoughts. We can take a little bit of break time, and I'm not going to use as much time in my summary.
Okay, sorry, but I thought it was 20 minutes, but
it was, unless I miscalculated.
Yeah, I think you miscalculated a little bit. So no, it's 31. Never mind. Tell me if you miscalculate, because then I'll feel less bad. So now I have to find my line of thought again. Okay, so what we try to do in that paper is think about what the value is of providing coverage, and then in a second step, what the value is providing choice in terms of coverage. And the value of providing coverage, that we know very much, it depends on what's the marginal value of an extra dollar of insurance, and that we want to compare with the marginal cost of providing an extra dollar of insurance. And we want to get that on average right in the population. So we want the average marginal value to be equal to the average marginal cost. But then if we want to think about providing the option to get more coverage, then we want to know whether the marginal value of an extra dollar of coverage for those who opt for it relative to that value in the population is sufficiently large compared to the marginal cost of providing that extra dollar of coverage to those who opt for it, minus the marginal cost of providing that extra dollar in the population. So for that to be true, heterogeneity in preferences is really key. Like, we need people to have very different valuations for offering choice to create some value. But conditional on heterogeneity in the value, heterogeneity in people's valuations, the value of offering choice will decrease to the extent that there's more selection on risk, or more selection on moral hazard, or more selection on frictions. And let me end with the thought that on all of these dimensions, empirically, we have relatively little information. Fortunately, there is the choice in the health insurance market, which allows us to try to get at these different dimensions. But even knowing these different dimensions in a given context to really evaluate it, whether providing choice is a good idea or not, let alone what the potential limits are when we're trying to decentralize the organization of choice, we need more empirical evidence on this. And so not just for evaluating having choice in health insurance, but also for evaluating choice in these other social insurance programs. So that's basically everything I wanted to cover, and I'll shut up right here. Thank you.
Thanks, Johannes. That was excellent, and covered a lot of ground, and I think opened up some of these really important issues. And both panelists, I think it was a great overview of two kind of really important examples of managed competition. And I think we sort of know it in the background that that's what's driving the ACA, but to the theme of this entire conference, there really are very strong parallels, even without sort of grand changes in the US system, that managed competition can provide insight to the US, and actually vice versa, arguably, that there's a lot to be learned across countries here. So let me ask a couple of questions that have come up. So Samantha Byrne had asked a question related to the recent paper showing there's heterogeneity in mortality across Medicare Advantage plans, and depending if we, the degree to which we believe that is there evidence for mortality differences also between plans in the Netherlands and in Germany? Do we know much about sort of those effects there for either one of you?
So I think on the German side, I don't think there's any evidence on this. I think people haven't looked at this for a number of reasons. Data limitations is sort of one of the big problems in the German system. These data are very hard to access. But I think in general, I would be surprised if there were differences. I mean, the plans are really very similar, and sort of, the provider networks, everything is the same. So I would be surprised if there are differences that are driven by the plans themselves. There could still be sort of leftovers. The residual coal miners and their coal miners plan are probably having a higher mortality. But you could probably not attribute that to sort of the plan design or plan management. That would be my hunch.
So, Johannes, do we know anything about the Dutch context? I'm guessing the answer is not much, but I don't know.
Not much, I think, no.
Yeah. So one other question, and I think this is with sort of the big themes we've had here that Ben flagged, and I would agree with this as being interesting. Do we know much about whether insurers are actually innovating or adding value in this context? I think that's an important assumption embedded in the kinds of, what we might want to get out of competition, but it's very rarely asked. And I think Stephen yesterday said that in Australia, actually, we don't think there's a lot of innovation there. So I don't know if you have any thoughts on whether we can measure that, or whether there are sort of efforts to do that, or even just casually kind of what we might want to look at in the two contexts you've looked at.
Well, so in the Dutch case, or in the Dutch context, within this dimension of the deductible choice that I've been looking at, we know that there are enormous differences in the quality of choice that individuals make across insurers as well. So there are some insurers, there are some extreme outliers where the choices that our individuals are making are like very close to what a rational consumer would do, and then there are other insurers where this is where people are making very bad choices. So we haven't looked further than that, but that's for sure a dimension in which we see big differences across insurers as well.
I think in the German case, you could say that these plans are certainly innovating. One question is whether it's good innovation. They certainly got more savvy at risk selection and upcoding and other kinds of things, sort of getting money out of the payment system for sure. I think in general, the the reason why Germany introduced competition is partly because it wanted to spur innovation, but the bigger reason I think was this kind of equity equality issue of the contribution rates being different for the same product. So that this fundamental concern about fairness. And so to that degree, whether that actually worked or not is sort of one question, but this sort of secondary maybe objective of competition for innovation in Germany is a bit tricky because the plans are so heavily constrained. And to some degree, the innovation maybe happens on a system-wide level. So it's not individual plans that maybe have large scope for innovation, but whatever they come against something, maybe this gets taken up by the sort of policymakers and then sort of included in this overall framework that policy and government basically sets. So that includes things like, this having a supplemental contribution rate, the supplemental fee, risk adjustment, other kinds of things that are more systemic. And on the plan side, there is some sort of a leeway to allow these bonus programs for preventive care, other kinds of things like this are sort of, basically loosening up restrictions on the plan so they can innovate in that direction. So it's very much sort of directed and sort of allowed innovation in that sense. I think when it comes to these sort of smaller features, there are arguably some valuable things that plans have come up with, like, offering whatever phone service hotline to help people make appointments at specialists or whatever kind of thing. But I think from the American perspective, and in general, these are really minor innovations and sort of more on the sort of service quality or customer service front than on care management. They are not allowed to manage care really in that sense. They have some integrated care contracts now and can do a little bit around it, but not really very much.
I'll ask one last question. There's a lot more, but we're going for the sake of people's break. But I was interested in this sort of corporatist bargaining model that you mentioned, Sebastian. I mean, I think you alluded at the end to the difficulties, but I wanted to see if I could press you a little to think more about to what degree or what this looks like in practice. How do they structure it? And is this something we should be thinking about here? To John's political economy point about the inability to take $1 trillion industry and just remove it, but different kinds of bargaining. And I would add that, Kaiser Permanente is effectively 3 groups that have to come to a structured bargain every year. So I don't know if you have any more context on how that occurs or even the history of that. Is this something that just goes along with the broader labor management integration you see in Germany generally, or is this something you think could be exported?
Yeah, so I think that's a really interesting question. I think this is sort of the basic kind of bare bones of the German health insurance system. Is one of the principles that's been around for a long time, so it's very ingrained in that sense. And the way this basically works is that the government would sort of set the basic parameters and sort of guide policy, right? They would say, 96 we start competition, and in 2009 we introduced morbidity-based risk adjustment. And so the government basically says what's being done. They introduced DRG payments in 2003, and this just applies to the entire healthcare system. They basically say, we want you to come up with a health sort of a payment system for hospitals. Go forth and do, and then these stakeholders get together and settle on the Australian version of the DRG payment or whatever it might be. And so I sort of struggle to think how this would work in the US, and sort of the idea that they all negotiate prices together and payment rates, not just the systems, how things are paid. I'm not quite sure how this would work in the US. I think the standardization sort of we can see in the exchanges, I guess, to some degree in some of the Medicare programs. It's not so much the different actors getting together and hashing it out, although maybe that is the political process after all. So I'm not quite sure how this would apply to the US context. It's a good question, and maybe there's sort of scope within some of these programs to force that within the government programs, maybe Medicaid or something. But yeah, it's sort of difficult to envision how that would work.
All right. Well, thank you. Thanks to both of you. That was incredibly informative and continuing in a theme, at least for me, for this entire conference. So we're slightly behind, but that's okay. Because as I said, I'm going to cede some of my closing remarks back. So let's take a 10-minute break for the group. We'll come back here. I have 10:42, so we'll only be 2 minutes behind. But let's do it. Let's do it in even numbers. We'll go until 10:55 Pacific and whatever that is in your time zone. So we'll take 12 minutes from now. I'll see you back here shortly for our innovation discussion with Matt Grennan and Amitabh Chandra.